Hello, doctors. You know what? This is Dr. Bruni here joining you live on YouTube and Facebook. And you know what? I want to suggest that if you are hearing me, just send the link to your friends, so that they can join us. We're going to have an exciting time of studies today. Frankly, we're going to enjoy the studies. So please, if you can just send me, a hi and let me know where are you joining us from, and how did you hear about this? Did you get it through an email? Did you see it because you're in our Facebook group? How did you hear about this? I'll be very, very glad to hear from you, because today we have a power-packed class, a power-packed class. I think that the things we're going to study today are very, very important and very, very critical for your exam preparation. So you can join us on YouTube right now, and you can also I'll suggest that just click on our subscribe button, and just subscribe to our YouTube channel, because we want to grow the channel and also make sure that people are getting the benefit of what MedCognito has to offer. So I have many people join. Oh wow, some are joining us from Australia. So Dr. ESTM says, hi, Dr. Bruni, or hello, Dr. Bruni. Awesome. Hello, doctor. And then we are getting someone from Australia as well. Australia. So that means that, MedCognito is really is coming of age, and it's awesome. Okay. And then we also have someone joining us from Ottawa. So that is our political capital city. Okay, so join us from Canada. Awesome. Please, so take advantage of the time. Just call your friends. I want to just give you some time. Just call your friends to join us right away, so that we can all get together. So in the next 1 minute, we're going to start. Okay, so just encourage your friends to join us, encourage them to Okay, so I'm back. And as I said, just invite your friends to join us, so that we can all join study. So Dr. Ozigi says, hi, Dr. Bruni. My response to him is also, hi, Dr. Ozigi. We are here to study. By the way, please, if you don't have your study guide yet, let me know. If you don't have your study guide yet, if you've not downloaded it yet, let me know, so that we can send you the link right now. You can download it on Facebook, on YouTube, in the YouTube link. So please kindly let me know, so that we'll send it to you. In fact, what I'm doing is I'm going to put it in the comment section right now, and you can use that to you can download and use that for your studies. Okay, can use that for your studies. So I'll look for the link and then send it. Meanwhile, today's session is going to be awesome, going to be power packed, and we're going to learn a lot. It's going to be an exercise we are all going to practice together. So I'm not going to be the only one speaking. You're all going to be part of it, just to make sure that we get the best out of the studies today. To get the best out of the studies today. So those who are asking for the study plan, I'm putting the comment in the comment section, so it will appear in your YouTube. So Dr. Modebelo is joining us from Waterloo. Awesome. So yeah, I've put the link in the comment section on Facebook and YouTube. Just click on it and download it for your personal studies. Please invite your friends to join us. So today's topic is very, very important, and the topic is about principles of generating good differentials. Okay, principles of generating good differentials for the for your case on the MCCQE1 and the NAC OSCE. And the reason why I'm doing this together is because the MCCQE1 and the NAC OSCE all have the same objectives. Okay, they all cover the same objectives. So if you are learning for MCCQE1, the same learning principles you take it to the NAC OSCE. The only thing is that the NAC OSCE is more of you talking clinical exam. The MCQE1 is an MCQ and a CDM exam, and a CDM exam is going to end in November 2024. So from next year, there'll be no more CDM. And someone may ask, Dr. Boni, why are we going through this exercise? For me, it is one key reason. And the reason is very simple, that if you have a systematic approach to differentials, having a systematic approach to differential diagnosis matters a lot on a board exam where you have very little time to think. And why do I say that? In the MCCQE1, you have 1 minute, 10 seconds to think during the MCQs per question. Okay, during the MCQs per question. So that is why we are making it a point that today we're going to focus on how to generate differentials. Now, why do you have to be systematic in generating differentials? Why? Someone may ask why. Why is Dr. Boni, worrying himself, to talk to us about how to be systematic in generating differentials? Number one, if you are generating differentials, it increases your accuracy and precision. And if you are generating the differentials, you will realize that it really, really helps you in the way you're going to be laser focused so far as making your diagnosis is concerned. So it provides a well-rounded, evidence-based approach to your answers. Okay, that is why you have to have a system. Number two, why do you have to be systematic in generating your differentials? It ensures comprehensive thinking, and it also ensures that you avoid missing potential diagnosis. Not every headache is a migraine headache. Not every chest pain is a myocardial infarction. So if you have a systematic way that you're going to go through your differentials, that is going to be a game changer for you. Number two, it increases accuracy and precision and provides a well-rounded, evidence-based approach to your answers. And I think we've already talked about that. And number three, why should you be systematic in generating your differentials? It optimizes your time management. Because as I said, you're going to have 1 minute, 10 seconds per question in the MCQs. So what you want to do is to make sure that you've optimized your time management very, very well. Okay, so that is why we are going through this today. Now, someone may say, especially for the MCCQE1, why is mastering differentials and how the differentials present a good exam taking strategy, and why are we doing that today? And the reason is very simple. 40 to 50% of questions in MCCQE1 focus on assessment and diagnosis. When I say focus on assessment and diagnosis, what I mean is that it focuses on what are the unique features in the case that will help you to make that particular diagnosis. Okay, 40 to 50%. So that means that 1 out of every 2 cases is going to focus on, okay, you see this, that, and that. What is your diagnosis? Or you see this, that, and that. What are possible diagnoses you need to think about? And someone may ask me, how did Dr. Boni know this? Because I review the MCC materials very, very well. This part, this one. And why am I focusing on this? Look at something here. If you look at the dimensions of care, maybe you may not see that, but if you look at assessment and diagnosis, how the questions are distributed so far as physician activities are concerned. Okay, now it says that assessment and diagnosis, you're going to get about 45 plus or minus 5% of the cases focusing on assessment and diagnosis. 45 plus 5 or minus 5. So 45 minus 5 is 40. 45 plus 5 is 50. So that means you're going to get about 40 to 50% of your cases focusing on assessment and diagnosis only. And that is why I think that while you are studying, you must pay particular attention, because if 4 out of every 10 questions you meet, or 5 out of every 10 questions, or 1 out of every 2 questions you meet is going to ask you about assessment and diagnosis, then you must have a system to break it down. Please, doctors, if you are following with me, just type yes, 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 so that I know that you are really, really following me. If you are following my point so far, just type yes, 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 Dr. Bruni, yes. Because for me, I want you to know why we do what we do in MedCognito. Why? Why are we focusing on, assessment and diagnosis today? Because for me, it's very, very important. If you are not doing it the right way, it's meaningless. All right, good. So that means I have quite a number of doctors following me on that. If you are getting about 40 to 50% of your cases, focusing on assessment and diagnosis, then it's good that you learn how to master it very, very well. Okay? You learn how to master it. And as we are going through, as I said, click on the subscribe button on our YouTube, and then let's get the ball rolling. Okay? So good. So 40 to 50% of the cases will focus on assessment and diagnosis. Number 2, 30 to 40% of the cases will focus on management. So maybe another day we will take another class on management principles, so far as the MCCQE1 is concerned. Then, when it comes to communication, you're going to get just about 5 to 15% of the cases focusing on communication. Okay. And then when it comes to professional behaviors, that's what people talk about, ethics. Oh, Dr. Bruni, ethics. Everyone is afraid of ethics. You're going to get 5 to 15% of the cases. So the distribution of ethics and communication is similar. But the one with the highest distribution is assessment and diagnosis. And that is why we are starting with that. Okay. So my question is this: how should we approach differentials in the MCQ1 exam? How should we approach differentials in the MCQ1 exam? Because for me, that is very, very critical. How should you approach differentials in your MCQ1 exam? And today, I'm going to let us all use vindicate. Vindicate. So please, if you're following me, I need you to type vindicate. Vindicate. Because we are going to use that to go through a systematic approach, which all of us have to start using from today. Vindicate. 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 Beautiful. Dr. Ogunlade has already typed it. Vindicate. Vindicate. Look, because if you can write this down and you can apply this all the time to your case, you'll be fine. So what do I mean by that? Anytime you have any case that you need to generate differentials from, whether it is in your NAC OSCE, whether it's in your MCQE1, just write vindicate on your page, on your paper. Okay? And then start. V means vascular. Vascular. So this particular presentation the patient has, what are possible vascular causes of that particular case? I means infection. So for example, I have a patient with a headache. So those who are listening right now, if I have a patient with a headache, can you type in some vascular causes of headache? I want to know. I'm just using headache as an example before we dive into one of the key objectives, headache. Can you type what are some vascular causes, or what are some of the causes of headaches which can have a vascular origin? So if you're thinking about vascular, think about a vessel bursting. Beautiful, beautiful, beautiful. So Dr. Nandini went for subarachnoid hemorrhage. Okay, Dr. Jakilu went for cerebrovascular accident. That's a stroke. Dr. Tobo went for subarachnoid hemorrhage. ASH. I don't know what ASH is about. Beautiful. Dr. James Asante went for giant cell arthritis. So doctors, you see, this is what I'm talking about. And this is what I want us to do. Okay, so now that we've talked about giant cell arthritis. Let me just even get a page, a fresh page, okay? And then let's just do this exercise before we even move on. Headache. Vindicate for headache. Vindicate for headache. Let's do that. Then we'll go into one of the objectives as well, and then we will use it, okay? Vindicate for headache. Let me say it. Vindicate for headache. Okay, I'm going to share my screen so that we all use that. We all go through headache before I even go through the other things I think we should focus on. So vindicate for headache. Okay, so we've done this is just by the by, okay? I just want to make sure that we are all getting it. So we're going to use vindicate for all our differentials, okay? So V, and we are looking at vascular. V, vascular, okay? So some said subarachnoid hemorrhage. What else are some doctors saying? Some said temporal arthritis. What other we are focusing on V now. We are focusing on V now. We are just focusing on V. Okay, so berry aneurysm, vasculitis, hemorrhage. Okay, let me write those down as well. Vasculitis, subarachnoid hemorrhage. Some said stroke, and the stroke will come back to that. Okay, so the I is infection. So you have the patient with headache. I for infection. Please, can you tell me some infectious causes of headache? So let's move away from V. Let's go to I. Let's go to I, infection. Some of the infectious causes of headache. Please, let's go. Meningitis. Beautiful. Meningitis. Beautiful. Meningitis. So let me make sure that we're doing vindicate for headache. Meningitis. I, meningitis. What are other infectious causes of headache? I for meningitis. Who else has something? Encephalitis. Beautiful. Encephalitis. What are the other things? Remember, we've not started a class yet. This is just by the by. So someone said fungal meningitis, encephalitis. Okay, beautiful. So fungal meningitis. Okay, now let's go to N. N is neoplasm, right? N is neoplasm. So what are some neoplastic causes of headache? What are some of neoplastic causes of headache? Okay, and someone added sinusitis. Beautiful. So we're going to N. We're now going to N. We are now going to N. So I want to know N. What do you say about N? Neoplastic causes of headache. I want to know, what will you say about that? Neoplasm. N. What are some of the neoplastic causes of headache? Neoplastic causes of headache, please. Just let me know. Neoplastic causes of headache. Okay. Neoplasm. What are some of the neoplastic causes of headache? Let me see the answers. Okay. Glioblastoma. Well, yeah. So people are going deep. So glioblastoma. Okay, what else? Medulloblastoma. Okay. So Dr. Salel says tumor. Please, maybe you can say intracranial space occupying tumor. Then, okay, so intracranial space occupying tumor. Then I think someone also said, let me see, another answer there. Oh, acoustic neuroma. Beautiful. Astrocytoma, acoustic neuroma. Okay, so astrocytoma, acoustic neuroma. Okay, let's go to vindicate. So D, 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 D. So D is degenerative. What are some degenerative causes of headaches? What are some degenerative causes of headaches? Can somebody help me? What are some of the degenerative causes of headaches? Degenerative causes of headaches. Degenerative causes of headaches. Who can help me? No, we are on D, 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 D. Well, Alzheimer's may not cause headaches per se. Okay, MS, multiple sclerosis. So people are going for all. So doctors, you see the exercise we are going through. So now, if you are met with something, just make sure that you are calling on vindicate, and vindicate is what is going to help you. And we're going to go back to it. So V stands for vascular. I will go for infections. Okay, so whether it is abdominal pain, whether it is leg pain, so that you're not just stuck and going like, oh my goodness, what is the answer I'm going to give? N stands for neoplasm, and the neoplasm can be benign or malignant. Okay, D stands for degenerative changes like arthritis and Alzheimer's, and then I stands for intoxication. So like drug overdoses, medication use. So for example, even medications, right? Drugs. Then C stands for congenital. So the person who was talking about Berry's aneurysm and all those things, you can put the Berry's aneurysm under C, congenital. And then A is autoimmune conditions. Autoimmune conditions. Autoimmune conditions which can lead to that particular condition you're thinking about. And A can also be allergic conditions, which can lead to that particular condition. And then T is trauma. So you see, if the patient has fallen, the patient takes maybe some blood thinners and has fallen and is bleeding, right? And then E is for endocrine causes like diabetes and hypothyroidism. So this is just a general overview of vindicate, okay? Vindicate. And we will use that to, get things going. So now let's try this vindicate thing on an MCCQE1 objective. Doctors, please, are you following me? If you're following me right now, just type yes, yes, yes. Let me go back to some of the answers some doctors gave for the headache, lymphoma, metastasis, beautiful, NF1. So you see, doctors, it broadens your horizon. So I want to ask, can I move on? Can I move on? If I can move on, just type yes, 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 so that I'll know that. So Jeanette Jew says, I am in class. I'm in class. Beautiful, beautiful. I like it that we're able to, impact as many doctors as possible in class. And then Dr. Nandini went on with extra drawers. So, okay, so we are now going to move into try this vindicate thing on an MCQ1 objective. And we're going to use it on abdominal distension. Abdominal distension, abdominal distension. So, doctors, buckle your seatbelt because we are going to get into abdominal distension right away. Abdominal distension. Okay, good. So, if I'm to give you a CDM-like approach question, so far as abdominal distension is concerned, I'm going to give you a question right now, and then let's see. This term is very long, but I'm just putting it out there. So, a 54-year-old female presents the clinic with a 2-month history of progressive abdominal distension. She reports feeling bloated and uncomfortable with intermittent nausea and occasional vomiting. Okay. Her appetite has decreased and she feels full after eating small amounts of food. She denies any recent changes in bowel habits, but mentions occasional constipation. Her past medical history includes hypertension and a 30-year history of smoking. On examination, her abdomen is distended, abdominal distension, with shifting downwards and mild tenderness in the lower quadrants. There is no palpable mass, but fluid wave testing is positive. So I'm asking you this question based on the clinical presentation, because we are learning vindicate. That's why I put the question that way. Generate 7 differential diagnoses for this patient's abdominal distension, ensuring that they come from different etiological causes. Powerful question. Awesome question. I just want to, make sure that we are playing in the realms of vindicate. So I ask you, give me 7 differentials, and those differentials must be in different etiological causes. So that means if you give me one infectious cause, you can't give me another condition which is an infectious condition. Okay, and the only way you can ace something like this is to use an acronym. We have another other acronyms, that people can use, but Vindicate is awesome. Okay, so remember we are using Vindicate for abdominal distension. So if you were supposed to give your answers, if we're starting from V, vascular, okay, vascular, it could be portal hypertension. Portal hypertension. Why? Because of chronic liver disease, right? It can lead to ascites. Then if I move from vascular to infectious causes, it can even be a patient with tuberculous peritonitis or a patient with chronic pancreatitis which has produced ascites, okay? Which has produced ascites. And then if we go to neoplastic, it could be that the patient has an ovarian cancer or hepatocellular cancer. Okay, and Dr. Arafat, the hepatocellular cancer can be as a consequence of some hepatitis the patient has developed in the past, right? Good. And then you can also have idiopathic, like if the patient has post-surgical adhesions. So maybe the patient has had a past history of abdominal surgery, right? And because of that, the patient has developed adhesions and it is now causing intestinal obstruction. And it could even be that the C stands for congenital. So like polycystic kidney disease. And the E stands for endocrine and metabolic causes. So like a patient with hypothyroidism, because they can have some form of myxedema, which can lead to distension as well. So doctors, I'm just trying to let you know that this principle of Vindicate can be used for almost every objective, so far as you are very systematic. So if I say somebody has red eye, what are your differentials? So you should be able to tell me vascular causes of red eye, infectious causes of red eye, neoplastic causes of red eye, degenerative cause of red eye, or even drugs which can lead to red eye, idiopathic or iatrogenic. So what the doctor can do, which can also cause the patient to get red eye, congenital causes of red eye, and some metabolic and endocrine causes of red eye. In the same way, if I say you have a patient, like there's an objective which talks about the floppy baby, right? Or an objective like chest pain, or an objective like abdominal pain. So all these are the things I'm just talking about, that so far as you have Vindicate, you should be able to fit everything in and deal with it. Doctors, are you tracking with me? Are you tracking with me? Just type yes, 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 so that I know that you are tracking with me. Just type yes, so that I'll know that you are tracking with me, because I really want to make sure that everybody is tracking with me. Okay, and please go to our YouTube channel as well, subscribe, like, and share our YouTube as well, so we can use Vindicate to generate everything. And I'm hoping that this class is becoming helpful. So abdominal distension objective using Vindicate as a guide for differentials. You must now, after we've been able to generate those differentials, how will you be able to tell that this presentation is ovarian cancer, this presentation is intestinal obstruction, this presentation is chronic liver disease leading to ascites? So that is the next level we are going to go to. And that is the exercise I want you to do if you are studying independently and you want to be able to master these things. This is how you want to go around it. Okay? Using Vindicate as your basis. So we talked about V, portal hypertension. What are the vascular causes of abdominal distension? Number one, we talked about portal hypertension, secondary to chronic liver disease. Number two, it could even be abdominal aortic aneurysm. It will not be obvious abdominal distension, but you realize that maybe the abdominal girth is big, right? Mesenteric ischemia. I think as we're going on, someone had mentioned it. That's Dr. Nandini Nagaka. right? She had mentioned the issue of mesenteric ischemia, and we will come there. Now, we are going to go through a systematic exercise right now. And my first question is this. Write out your unique equation, which will help you to identify each of the above diagnoses. So, how will you be able to tell if you are in your MCQ1 exam, a case which is presented based on the objective of abdominal distension, that this patient has portal hypertension? How will you be able to tell? How will you be able to tell that this patient has abdominal aortic aneurysm? What are the key words that you're going to use? So, and that is what we are going to focus on. Okay, so let's start. Portal hypertension. Please, doctors, everybody, write your pointers. Write your pointers for me. Write your pointers for me. Write your pointers. What are the 2 or 3 things you want to see in a STEM which should direct you to portal hypertension? Let's start with that one. Portal hypertension. So we're going to go through all the acronym, Vindicate, and all the differentials. So today is going to be a long day. Vindicate. Okay. So portal hypertension. Portal hypertension. What are the key words you are looking for? What are the key things you are looking for in your STEM that will help you? So someone is going for caput medusae, varices, hemorrhoids. Beautiful. Dr. Nwodo says, I'm going to look for jaundice. So we are going to just write medical equations today. Okay? Medical equations today. Dr. Akano, even before you get to caput medusae, what are some other things that you are expecting to see in a STEM which should point you to portal hypertension? Apart from caput medusae. Dr. Nandini says ascites. Apart from caput medusae, what are some other things which should point you to portal hypertension? Well, someone says esophageal varices. Esophageal varices, you will only see esophageal varices if you do a scope, right? Someone says blood from paracentesis. Blood from paracentesis, really? So I'm going to make it very simple for you. Pulmonary erythema. So you're basically talking about the signs of chronic liver disease, right? This other person is saying, spider angiomata, caput medusae, increased JVP, jaundice, ascites. So this is what I will say. How and what to look out for to think about portal hypertension. Number 1, look for that patient who has signs of cirrhosis. So all the things you talked about, pulmonary erythema, clubbing, all those things can come in. A patient who has ascites. So cirrhosis plus ascites plus varices. And the varices will be noted if you are told that the patient has done an upper GI scope and the patient is noted to have varices. Or maybe the patient is having upper GI bleed, the patient has jaundice, and also you may be looking out for in your questions then, does the patient have a history of liver disease? Liver disease. If you don't have a history of liver disease like chronic hepatitis, maybe look out for the patient who also has alcohol use. So a patient with alcohol use or a patient with history of hepatitis, chronic hepatitis B, history of chronic hepatitis C with cirrhosis and ascites, think about all this coming together to cause portal hypertension. Look for caput medusae, which a lot of doctors have talked about. Okay, caput medusae, which a lot of doctors have talked about. And jaundice will also be a very good one. Okay, so doctors, I want to move on from this equation. Well, Dr. Nandini, the issue with mental confusion will come in if the patient starts developing hepatic encephalopathy. Okay, so your equation will be cirrhosis plus ascites plus varices, maybe in a patient with long-standing liver disease, alcohol use, developed portal abdominal distension, has caput medusae or esophageal variceal bleed. Okay, this is your first equation. Okay, so what about abdominal aortic aneurysm? Abdominal aortic aneurysm. Abdominal aortic aneurysm. What are the pointers in your question stem which should cause you to start thinking about, okay, this patient, I've seen this, that, and that, and if I put this together, I think this patient has abdominal aortic aneurysm. Doctors, please type in your answers, type in your answers, type in your answers. While you are doing that, please subscribe to the YouTube channel, okay? While we are doing that, please make sure you're subscribing to the YouTube channel as well. So I'm waiting for your equation on your equation on aortic aneurysm, abdominal aortic aneurysm. Your equation on abdominal aortic aneurysm. I'm waiting for that. I'm waiting for your equation on abdominal aortic aneurysm. Okay? Abdominal aortic aneurysm. What does your equation say? Click to subscribe to the YouTube channel. Okay. So somebody says this. Dr. Vanessa says this. Elderly patient, non-controlled hypertension, long-term tabagism. I'm saying, what are the things the history will tell you? What are the things the history will tell you? So somebody says history of smoking. Yes. But what are the things which are, Dr. Ufanenya says history of smoking. But what are the things which are specific, which are unique? You know, referred visceral pain affecting the back. Okay. Abdominal aortic aneurysm. It says tearing abdominal pain, pulsatile abdominal mass, smoking. Okay, good pointers there. So, abdominal distension in a patient with a pulsatile abdominal mass. Please don't miss that one. Pulsatile abdominal mass. Pulsatile abdominal mass. It should lead you. So as soon as you see that word, pulsatile abdominal mass, boom, it should lead you to that. Okay, Dr. Titilope says history of hypertension and smoking, the new back pain, pulsatile mass on examination is highly suggestive of abdominal aortic aneurysm. Okay, good. Doctors, please, I hope you are now getting what we are doing. So first, we used Vindicate to generate our differentials, and then now we are looking at all the components of Vindicate, the V, 3 top diagnoses you should not miss, right? And what are the key words you should be looking out for, which should lead you to that. Okay, so we've dealt with abdominal aortic aneurysm. Now let's go to something different. Chronic mesenteric ischemia. Chronic mesenteric ischemia. Chronic mesenteric ischemia. What are your pointers? Remember, I didn't talk about acute mesenteric ischemia. Acute mesenteric ischemia, your pointers can be, somebody with atrial fibrillation who has abdominal pain, which is out of proportion to the presentation. I'm talking about chronic mesenteric ischemia. What are the pointers which will lead you to start thinking about chronic mesenteric ischemia? I'm waiting for your answers. What are the key things you are expecting to see which should lead you to think about chronic mesenteric ischemia? Someone is saying history of MI. Beautiful. This one, Dr. Luquici said history of atherosclerosis. History of atherosclerosis. Dr. Jackie Lewis said history of hypertension, history of dyslipidemia, history of coronary artery disease. Okay. Dr. Nandini says hypertension. So what are the pointers? Chronic mesenteric ischemia. The patient will present with pain out of proportion after eating. You realize that now the patient has abdominal pain. Whenever I eat, there is pain. Beautiful. Dr. Tobo got that right as well. Abdominal pain after eating. If a patient has severe abdominal pain but minimal findings on physical exam, and especially the patient describes pain after meals, postprandial pain, in an elderly person, yes, you can think about gastritis. Yes, you can think about dyspepsia. Yes, you can think about peptic ulcer disease. But another diagnosis you don't want to miss is chronic mesenteric ischemia. Chronic mesenteric ischemia. Doctors, chronic mesenteric ischemia. Okay? Chronic mesenteric ischemia, we call it abdominal angina or gut angina. And yes, you can also look out for that patient who has atherosclerosis as well. Okay, good. Now we are moving from the vascular causes to the infectious causes of abdominal distension. And some of the answers can be peritonitis, ascites due to bacterial peritonitis, tuberculous peritonitis, okay, hepatitis, which can be viral or autoimmune, and chronic pancreatitis. So now let's go through the same exercise. What in your question stem will cause you to think about peritonitis? What are the pointers which as soon as you see this, that, and that, should cause you to think, okay, this is peritonitis? What are the things which should cause you to think that this is peritonitis? Doctors, let's go. How will the patient present on history? How will the patient present on maybe physical exam? Okay, so free fluid, yes. Rigidity on examination of the abdomen, yes. Garden, okay. So Dr. Jakilu says acute abdomen, but Dr. Jakilu, I'll request that maybe you make it more specific, right? Acute abdomen, make it more specific. Please make it more specific. Yes, it's an acute abdomen, but please make it more specific. Fever, beautiful, Dr. James Asante. Fever. So, what are the pointers in my board exam which should lead me to think about peritonitis? Number one, if I have a patient who has board-like rigidity. Number two, if I have a patient who has rigid abdomen, rebound tenderness, board-like rigidity with fever. So rigid abdomen, rebound tenderness, that patient looks very sick. That patient has fever. Think about peritonitis. So someone says fever with abdominal pain with rigidity. Beautiful. Those are the pointers. Okay, let's go to another one. Ascites due to bacterial peritonitis. What are the? It looks similar to the previous one, so I'm not going to belabor the point. If you have somebody who has cirrhosis of the liver, so I'm talking about spontaneous bacterial peritonitis. Okay, spontaneous bacterial peritonitis. This patient has ascites, and then all of a sudden this patient has started developing fever. At times they may even develop some altered level of consciousness and all those things. Okay. If you have a cirrhotic patient with ascites who develops fever or new abdominal pain, one diagnosis you don't want to forget about in your board exam is spontaneous bacterial peritonitis, and the commonest organism is E. coli. E. coli, E. coli, E. coli. Okay, so you want to know that. Okay, good. What about tuberculous peritonitis? Doctors, let's move on to that one. I'm very happy about the participation in the class today. Tuberculous peritonitis, tuberculous peritonitis, tuberculous peritonitis. What are you going to think about? Tuberculous peritonitis, what are your pointers? What are your pointers? Tuberculous peritonitis, what are your pointers? I want to start seeing the answers. Tuberculous peritonitis, what are your pointers, doctors? Tuberculous peritonitis, what are your pointers? Tuberculous peritonitis, what are your pointers? Please tell me your answers before I give some of the clues. Tuberculous peritonitis. Tuberculous peritonitis. Tuberculous peritonitis. Tuberculous peritonitis. Okay. Tuberculous peritonitis. What are the pointers you're going to look out for? You're going to look for somebody with ascites, but also has some night sweats as well, because this is, combination of tuberculosis, and then maybe the patient has weight loss, night sweats, yeah. So tuberculous peritonitis. Yeah, the patient may be presented as an immunosuppressed patient, maybe has a history of HIV, or the patient has just come from jail where they were overcrowded, right? Those are the pointers. Those are the pointers. Those are the pointers. Awesome, 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 awesome. Someone says chronic cough with abdominal distension plus fever plus weight loss plus nice. I'm very happy that now we are dealing with medicine like it's some, equation we are dealing with. I really like that. Okay, good. Okay, what about hepatitis? What are the pointers which will lead you to that? Pointers for hepatitis. What are the pointers which should lead you to that? We should lead you to that. Pointers, pointers, pointers. Pointers for hepatitis. Pointers for hepatitis. What are they? Hepatitis. I'm waiting for the right lower abdominal pain. Someone says right lower abdominal pain. For hepatitis, I'm rather expecting right upper quadrant pain. Right upper quadrant, not lower. Right upper quadrant. So, doc, maybe you may want to check your answer again. And then someone went for elevated transaminases. Okay, that's Dr. Vanessa Menezes. Okay, so please keep inviting your friends, keep encouraging them to, subscribe to our YouTube channel, subscribe, so that we can, get this good news to other people. Dr. Nandini says, IV drug use. Dr. Opeyemi Akano says abdominal pain plus jaundice plus hepatomegaly or associated autoimmune disease. So what is our answer? Think about jaundice, think about right upper quadrant pain, as I said. Think about elevated liver enzymes. Okay, so look, all these patients we've talked about have abdominal distension, but you realize that because you were systematic, and because you were very careful in the way you generated your differentials, these features then help you to, okay, this one goes here, this one goes here, this one goes. That's how you do it. No. Dr. Nandini says, I feel I'm in trouble. Am I? No, you're not in trouble. I'm just reading out everybody's answer. Okay, you're not in trouble. Sure. Dr. Azam says extremely high ALT and AST. So these are the things you want to look out for: jaundice plus right upper quadrant pain. Okay, and then elevated liver enzymes. That's awesome. Okay, let's move on to the next one. So, what are the features which should lead you to pancreatitis? Pancreatitis. What are the things you should look out for? Remember, we are using Vindicate, to help us to generate our differentials. We are using Vindicate to help us to generate our differentials. Vindicate to help us to generate our differentials. Okay, so pancreatitis, epigastric pain, beautiful. For pancreatitis to lead to jaundice, Dr. ESTM, there must be some, gallstone blockage somewhere, right? Dr. Eugenia says pain which radiates to the back. So, doctors, you see, we are just picking one objective. We've listed the differentials, and we are just going bam, bam, bam. How will I know this is the condition? How will I know this is the condition? How will I know this is the condition? Dr. Titi Lopez says it is position related. So look for epigastric pain, which radiates to the back. Look for those two words: epigastric pain. That pain radiates to the back. That pain shoots to the back. Okay. Dr. Akano also says chronic alcohol use, epigastric pain, elevated lipase and amylase, sure, which goes to the back. Dr. Togbo says epigastric pain which radiates to the back in a patient with alcohol use, because you see he's combining the risk factors for pancreatitis, right? It could also be, you could also say epigastric pain which radiates to the back in a patient with known history of gallstones, right? Good, beautiful. Now, doctors, do you need a break? I'm asking, do you need a break? Because we are not done yet. Do you need a break? Do you need a break? Because we are now going to go to the N. Vindicate. Remember, it is Vindicate. Do you need a break? Okay, sure. Dr. James Asante says, no, we don't need a break. Okay, so now let's go to neoplastic. Let's go to ovarian cancer. Let's go to colorectal cancer. Let's go to hepatocellular cancer. Let's go to lymphoma. Now, let's start. What are your pointers for ovarian cancer? How will you be able to tell that this question stem I'm being given? Boom, ovarian cancer. How will you be able to tell? Ovarian cancer. Beautiful. Look at Dr. Jackie Lugo. He says bloating, early satiety, abdominal pain. Beautiful. Bloating, early satiety, abdominal pain. Bloating, early satiety, abdominal pain. That's powerful. Does somebody want to add anything to that? Or you want me to just move on to the next slide? Does somebody want to add anything to that? Does somebody want to add anything to this? Bloating, early satiety, abdominal pain. So Dr. Jakilu says from Med Bullets. Yeah, so those who don't know, so Med Bullets are like part of our program, right? And it helps you to, like this particular exercise we are going through, it helps you to go through it very well. So Med Bullets have been very, very helpful to many, many candidates. So yeah, okay. So think about vague symptoms because before a lot of ovarian cancers are picked up, it's usually late stage, right? So vague symptoms are vague symptoms of abdominal pain, bloating, the patient is always full, they have some pelvic heaviness. Think about that. As I said, it's like a silent killer because by the time you pick it up, it's far advanced, right? Because so the patient might have seen many doctors. The doctor said, "Oh, this is dyspepsia. Oh, this is constipation. Oh, this is this," and then by the time someone actually does some investigations, boom, there's trouble. Okay, so doctors, what are the things which will point you to colorectal cancer? Colorectal cancer. What are the things? What are the features that will point you to colorectal cancer? Please let me know. Colorectal cancer. Remember, we are focusing on the MCCQE1 objectives, and we are using Vindicate to help us to generate our differentials. Colorectal cancer. Colorectal cancer. What are the things? What are the pointers? What are the pointers? What are the pointers? What are the pointers? Colorectal cancer. Colorectal cancer. Colorectal cancer. So Dr. Jakilu says hematochezia, bowel changes, weight loss. Boom! Dr. Nandini says hematochezia. Dr. ESTM says blood in stool. Dr. Sylvie says, Saivili Musindi says hematochezia and weight loss. So Dr. Anjali says weight loss and stool and constipation. Well, colorectal cancer can go both ways. So you can, to even put it better, change in bowel habits. Change in bowel habits. Change in bowel habits. Unintentional weight loss from Dr. Tolu. Change in bowel habits. Passage of pellets too, because at times when the tumor is becoming big, it narrows the passage of the stool. Okay. So for colorectal cancer, think about a patient with change in bowel habits. Think about a patient who has blood in the stools. Okay. Think about a patient who is over 50 years, even though you can get some people who are less than 50, but in a board exam situation, think about a patient who is over 50 years. Think about that patient who may present with abdominal distension because now the patient is developing ascites as a result of that. Patient who has changes in bowel habits, occult blood in the stools. When you see these words like that, you start thinking about colorectal cancer. Colorectal cancer. Okay, what about hepatocellular carcinoma? Hepatocellular cancer. What are the features which will lead you to start thinking about hepatocellular cancer? Hepatocellular cancer. Please let me know. What are the features of hepatocellular cancer? Hepatocellular cancer. What are the features? Features of hepatocellular cancer. Please let me know. Features of hepatocellular cancer. What are the features you are going to look out for? Features that you're going to look out for hepatocellular cancer. Please type your answers. Let's go. We still have quite a lot to do. Hepatocellular cancer. Features. What are the things which should cause you to think that this patient has hepatocellular cancer? Okay. So Dr. Mohammed says hepatic nodal swelling. I don't know what that is. Dr. Mohammed, maybe you want to put your answer right. Dr. ESTM says weight loss, fever, malaise. Dr. Jackie Lou says jaundice, ascites, bipedal edema. Sure. Dr. Luquichi says hepatomegaly, that is nodular. Right upper quadrant pain with weight loss and jaundice. Liver cirrhosis with, okay, beautiful. So what are we looking for? We're looking for a patient with liver cirrhosis who has also developed weight loss, okay? And in patients with a history of cirrhosis or chronic hepatitis, hepatocellular cancer usually presents as unexplained weight loss. And Dr. Titi Lopez says pruritus, jaundice, splenomegaly, variceal bleeding, cachexia, increased abdominal girth, hepatic encephalopathy. So that is when you are getting to the later stages, right? Hepatic encephalopathy. Okay. So now let's move on from there. Let's go to lymphoma. What are your pointers? What are your pointers for lymphoma? What are your pointers, doctors? Tell me. You see this equation in the question step, you can easily say, okay, this is lymphoma. What are the things you're going to look out for? Tell me. What are the things you're going to look out for? What are the things? Lymphoma. Tell me. What are the things you're going to look out for? Lymphoma. Lymphoma. I'm waiting for your answers. Okay, so Dr. ESTM is starting with lymph adenopathy. Dr. Nandini says nodes. I'm sure she's talking about lymph nodes, right? Dr. Lukichi says B symptoms, night sweats, weight loss, anemia. Dr. Jakilu says fatigue and susceptibility to infections. Dr. Calvin says painless mass, weight loss. Dr. Tolu says daytime and nighttime sweating, non-tender lymphadenopathy, weight loss. So you're thinking about painless swollen lymph nodes, night sweat, weight loss, that's what is going to cause you to think about lymphoma. Okay, let's talk about degenerative causes and drugs. We've already talked about cirrhosis with ascites and then drug-induced hepatomegaly. For example, methotrexate, right? And constipation, which is secondary to opioid use, right? So, cirrhosis with ascites, I think this one, we've already gone through it over and over and over again. So, I'm just going to mention it. A patient with alcohol history, ascites, jaundice, okay, cirrhosis, which presents with ascites, okay, those are the features you're looking out for. Look for a patient with a known history of viral hepatitis. What about drug-induced hepatomegaly? Drug-induced hepatomegaly. What are you looking out for? You're looking for a patient who has a condition which is needing methotrexate to help treat it. Looking for a patient who is needing amiodarone. Looking for a patient who is taking alcohol for a long time. Okay, drug-induced hepatomegaly. All right, drug-induced hepatomegaly. What about opioid-induced constipation? This gives it away. So look for a patient who is on an opioid like morphine, hydromorphone, hydromorphcontin, fentanyl, those ones, those drugs, or a patient who abuses opioids, right, and is unable to poop and now has developed increased abdominal girth. What about iatrogenic? So, how will a patient with post-surgical adhesions present? Can you help me? Post-surgical abdominal adhesions, and then abdominal distension secondary to retained gas, especially the post-surgical adhesions. How will the patient present? Please, I want to know. Post-surgical adhesions. Please, I want to know. Tell me. Post-surgical adhesions. I want to know. Please, tell me. I want to really, really know. Post-surgical adhesions. Post-surgical adhesions. I want to know. Okay. Post-surgical adhesions. I want to know. how will the patient present? Or on the history, how will the patient present? Tell me. I want to have patience for you so that you can bring in your contributions. So constipation, sure. What else? The patient will not be able to pass stools or flatus, right? Or both. So previous abdominal surgery, abdominal bowel obstruction, and the bowel obstruction, if you look at an abdominal x-ray, you may see, features of bowel obstruction, Holstra. If it is large bowel, you may see air fluid levels on abdominal x-ray. If the patient has a previous history of abdominal surgery and they present abdominal distension, they may even have vomiting, no recent bowel movements. Okay. Participation in the class today has been awesome. Participation has been awesome. Okay. And the patient has had maybe some extensive bowel surgery. Okay. Now, the retained gas after laparoscopic surgery. Now, I want to just give the pointers so that we can wrap up. Think about a patient who has just had laparoscopic surgery, because in laparoscopic surgery, they pump some gas into your abdomen, right? And after the laparoscopic procedure, the patient may have some distension, even though they allow a lot of the gas to come out. And it could also be like idiopathic edema, where the patient develops, unexplained abdominal girth increase with normal labs, including normal liver function, normal renal function. Okay. Yeah. What about congenital? How will I be able to pick up polycystic kidney disease, congenital malformations of the GI tract, Hirschsprung's disease? What are the pointers there? In polycystic kidney disease, look out for the patient who has enlarged kidneys, maybe when you do your exam or when you do an ultrasound or you feel a mass in the flank. Okay. Hypertension. So if you have a patient with enlarged palpable kidneys with hypertension, one diagnosis you should not lose sight of is polycystic kidney disease. At the same time, if you have a patient who is an infant with bilous vomiting with abdominal distension, think about possible intestinal malrotation or volvulus. How will you be able to pick up Hirschsprung's? How will you be able to pick up Hirschsprung's disease? Think about that newborn who has not passed meconium yet. The meconium is, that dark greenish to dark colored poop that the infants pass. Okay? And they have abdominal distension with it. Think about that. Hirschsprung's presents in newborns with failure to pass meconium within 48 hours and severe abdominal distension. So if you start seeing those things, start thinking, okay, could this child have Hirschsprung's disease? Now let's go to the autoimmune. What are the features which will point you to celiac disease? Doctors, type in your answers. The answers have stopped coming. Type in your answers. Facebook, YouTube, type in your answers. What are the features which will point you to celiac disease? Celiac disease. Pointers that will lead you to think about celiac disease. Pointers that will lead you to think about systemic lupus erythematosus with ascites due to serositis. And pointers that will lead you to think about Crohn's disease. What are they? What are they? What are they? So celiac disease, think about that patient who has bloating. Anytime that patient takes gluten-containing foods, and they can also develop diarrhea as well. So if you have any patient who is developing bloating and diarrhea, which is triggered with gluten-containing foods, think about celiac disease. SLE, what are you going to think about? Think about that patient who has ascites with joint pain and butterfly rash on the face. SLE. Okay, Crohn's disease. What are you going to think about? Think about that patient who has bloody diarrhea with weight loss. Bloody diarrhea with weight loss. Bloody diarrhea with weight loss. Think about Crohn's, bloody diarrhea with weight loss. Okay, what about traumatic and toxic causes of abdominal distension? Blunt abdominal trauma, okay, which can lead to hemoperitoneum. So if you are told that maybe the patient was in a car, was involved in a car accident, whatever, or post-traumatic bowel perforation, or toxic megacolon due to Clostridium difficile or inflammatory bowel disease, right? So how will that present? Abdominal trauma leading to hemoperitoneum. Think about any patient who was in a trauma, right? Who presents with low blood pressure, maybe some palpitations, increased pulse, right? The patient is almost comatose. And then post-traumatic bowel perforation. Think about a patient with trauma plus rigid abdomen. What about toxic megacolon? Look for that patient who presents to the ER with fever, abdominal distension, with some diarrhea, and you are told that maybe the patient has inflammatory bowel disease or recent C. difficile infection. Think about those. Doctors, are you tracking with me? Think about those. Think about those as the reason why the patient is presenting that way. And what about endocrine causes? What about endocrine causes? If the patient has hypothyroidism, diabetes leading to gastroparesis, Addison's disease as well, which can lead to, fluid retention, and then Cushing's syndrome, when the patient has, central obesity. Okay, so I've just put the features here. Hypothyroidism, think slow, everything is down, so they are not passing stools well. Okay, and because of that, they develop this distension. Diabetes, the patient has poorly controlled diabetes, and because of that, they bloat easily after meals. That's what we call gastroparesis. Addison's disease, think about a patient with hyperpigmentation, low blood pressure, abdominal distension. You've given your fluids, the patient's hypertension is not correcting. Think about an Addisonian crisis, right? Abdominal pain, low blood pressure, which is not correcting with regular IV fluid unless you give a steroid. Think about adrenal insufficiency. And then Cushing's syndrome. Think about that patient who has a moon face, abdominal distension, that patient who has all these features but has thin limbs. The limbs are thin. So I'm very, very glad that, we've been able to go through this. So for now, doctors, please, if you tracked with me, remember the word you need to use whenever you need to deal with differentials is vindicate. Never jump into any conclusions. Take your time. Build it one by one. And that is when you're going to get the success you want. And so, like I always say, doctors, I have a question. I don't know whether anyone wants to join me on this live. I can put the link in the comment section if you want to ask a question or you want to contribute to what you've learned so far today. I'm putting the link there. If you are in a place where you think you can join me on this stream, you can click on it and join me. If not, I want you to know that, look, don't believe everything you think. Because for a lot of doctors, as I interact with them, many people have just, they've even, how do I put this? Dr. Brody, I don't even think I'm going to pass. Who said so? Who convinced you that you can't pass this exam? This exam is only about principles. Dr. Maria Asif says, superb. I think so. I think today's class has been awesome because in 1 hour, we've been able to review only, I don't even know the number of cases we've been able to review. So many cases with, the things you need to really know, the pointers. So when you see this and this and this, boom. You see this and this and this, boom. So Dr. Titi Lope says, awesome. Yes, the class has been awesome. And it will be on the YouTube page. You can always come back and watch it. And don't forget to subscribe to the YouTube channel as well. Okay? Because the more you subscribe, the more it grows and the more other doctors who need sessions like this can see it, and they can also join the MedCognito family. Okay, but I have good news for you. And the good news is that MedCognito is currently running a promo. Father Christmas came very early. MedCognito is running a promo. And you may say, Dr. Bruni, what promo is that? It is for the QE1 exam, 30% off. 30% off. Dr. Tobo says, this is beautiful. Yes, this is beautiful. 30% off. Doctors, 30% off. Okay? And I really want you to know that it's not going to last for a very long time. 30% off. So those who have been thinking about, how am I going to join MedCognito? How am I going to join MedCognito? This is the time. You can take advantage of this to join MedCognito now. Okay? You can take advantage of it to join MedCognito. And what do I mean by that? And that is the screen I'm sharing. So for the those who you can pay $367 a month on a monthly basis. The promo is going for, if you want to even use the payments plan, $299 a month for 6 months. Okay, and if you want, you could also pay it over 5 months, which was $440 a month for 5 months. We've reduced that to $359 a month for 5 months, and you still get access to everything for 6 months access. And those who are like, oh, the 1997, I cannot afford it, but I can afford something lower. 30% off goes for 1599. 1599. So I'm going to drop the link in the YouTube link and then the Facebook link. Okay, so you can just use it. Just click on it. It will take you to the registration page, and you can just register. This is just for a few days. This is just for a few days. So because we want to get as many doctors on the train as possible to prepare them. As at the same time, our mock exam is coming on next week Monday. Next week Monday. So if you've not registered yet, I'm putting the link in the comment section as well for the mock exam. Okay, so remember there's a promo going on, and I'm putting the link in the comment section for the mock exam as well. And there are a lot of doctors who want to reach out to me personally on my personal phone. I'm waiting for your call, and I'm putting my phone number out there. +1 306 891 5649. +1 306 891 5649. Send me a WhatsApp message right now. Send me a WhatsApp message right now. I'm going to respond to you, and we're going to help tackle your problems. Doctors, I hope today's session was helpful. And I want to say it again and again and again and again. Don't believe everything you think. Who convinced you that you can't pass this exam? Okay? Who convinced you? So on October 7th, we're going to have another mock. This time, it's going to be on MCQs alone. October 7th. It's going to be on MCQs alone. And many doctors have, taken the mock exams, and they are very, very happy about it. So this is Dr. Bruni, your friend from MedCognito. So someone says, fantastic lecture. Yes. Don't forget that we have the promo going on, and you can click on it right now to register. So doctors, take advantage of it. Take advantage of it. Take advantage of it. 30% off. 30% off. Fantastic lecture. Yes, I believe that. Such a great session. Yes, I believe that. And we're going to keep helping the IMG community till we all get to the finish line. That is our mission. That is our mission. That is our purpose. Remember, tomorrow there's going to be a class in the evening at 7 p.m. EST. So doctors, register so you can jump on board and start studying right away. As usual, and as you already know, this is Dr. Bruni, your friend from MedCognito, and we are all walking through this path together. And today we dealt with how to generate differentials for the MCCQE1 exam. And we learned that we are not going to be tunnel visioned. We're going to be broad in our differentials so we can get the best out of our NAC OSCE and our MCCQE1 exam. I'm putting the link to the promo in the comment section. Just click it, and register. Let's go out there. Let's go and ace the exam. Thank you very much. See you in class. Continue to study. Let's keep acing the MCCQE1. Thank you. Have a wonderful evening. Bye-bye. Bye-bye.